Hey guys, welcome to my clinical acid-base summary. In this video, we're going to cover acid-base disorders, metabolic, respiratory, everything you can think of, and I'm going to give you a quick algorithm to let you understand if you've taken a problem all the way to the end. We're going to go through each single disorder, how to identify it, what to look out for in terms of compensation, and then we're going to talk about metabolic acidosis, which has a ton of calculations associated with it. So jumping right into it, we have our PCO2 and our bicarb normogram here. PCO2, you have to remember that normal value is 40, bicarb normal value is 24. CO2 is going to be a representation really of respiratory status, bicarb is going to be a representation of metabolic acid-base status, and our normal pH is 7.4. So they're going to meet right here at 7.4. Okay? All right. So the one thing that is important to realize when dealing with these kinds of questions is that all of these types of disorders, metabolic, respiratory, right, all of them have their own algorithm. Don't try to group them into groups. Don't try to say this one's my respiratory group algorithm, this one's my metabolic group algorithm. Each single disorder has to be treated like its own type of disease. Okay. So before we get started with anything, we have to know what type of disorder we have. So there's two steps here that we have to do before we start our algorithm. The first is to determine if we have an acid or base condition, right? So are we acidosis or are we alkalosis? And the pH is 7.4. So let's do two examples, a pH 7.1 and a pH of 7.8, right? So here we have our acidosis condition and our alkalosis condition. Then we have to determine, is this metabolic or is this respiratory? Now here, I like to use logic to determine whether we're metabolic or respiratory, and I'll explain kind of how I look at it. So we have CO2, which is our respiratory marker, and we have bicarb, which is our metabolic marker, right? And we have our normal values. So when they give you the pH and they give you CO2 and bicarb, you see which of those values explains the pH that you're seeing. So if you have a high CO2, that's going to increase your acid. So high CO2, high acid. If you have a high bicarb, that's going to decrease the acid in your system, right? Decrease H+. Those two things are very important to know. So now let's say we're given a problem, and usually the CO2 and bicarb will either both be higher or lower than the normal values. They'll travel in the same direction, right? So we have a problem. They gave us a pH of 7.1 and they gave us a CO2, let's say, of 44 and a bicarb of 26. So both of them are high. Which one of these explains our low pH? So high CO2 would cause an acidotic-like condition, so it explains our low pH. So now we know we're dealing with a respiratory acidosis. So whichever change explains your low pH is the one that is the primary condition. A high bicarb is not causing a low pH, right? It would cause a high pH. And this high bicarb really is just a compensation for our high CO2, which is our primary condition. Okay, let's take another example. Let's say we have a pH of 7.8. So we're alkalotic. Now we have a low CO2 and a low bicarb. A low CO2 would explain this high pH. So in this case, we have a respiratory alkalosis, right? So whichever value explains pH the best is the one that is our primary condition. Okay. Usually CO2 will travel opposite to the direction of our pH change, and bicarb will travel in the same direction, right? So if you have, for example, an acidosis where the pH is low, the bicarb will be low to explain that low pH. So in that case, you have a metabolic acidosis, right? So whichever one moved in the direction that explains your pH change, that's the one you go for. I hope that makes sense. And then our step 3 is to look at our compensation. So is our primary disorder compensated for? And you have to realize that metabolic is always compensated by respiratory, and respiratory is compensated by metabolic changes. So they're compensated by their opposites. Okay, so here's our algorithm. We'll go through this one more time at the end, but just as a quick introduction. First we looked at pH, right? Then we looked at metabolic or respiratory, and now we're here. Okay, once we've gotten to this level, we go to the next level, which here is compensation, which I'm going to write as comp. Okay, for each of these, the compensation is calculated in a different way. For metabolic acidosis, you calculate compensation with Winter's formula. For metabolic alkalosis, compensation is calculated with 2/3 of the change in bicarb. And then for respiratory acidosis and alkalosis, we have these ratios that I'm going to explain in the next slide. Okay, so we have compensation in our second level here, and then you'll see in the third, fourth, and fifth levels we have things that have to do with only metabolic acidosis. That's why it's the most popular question. It has the most math to go along with it. So after you've determined metabolic acidosis, you also have to calculate anion gap. Then whether anion gap is negative or anion gap is positive, you have to do further calculations. So urinary anion gap is for negative anion gap calculations, and then you have to do osmolar gap and delta delta for positive anion gap. So this is also known as HAGMA. So high anion gap metabolic acidosis, you have to calculate osmolar gap and you have to calculate delta delta to really understand what's going on. Okay? All right, so let's talk about our second level here, which is compensation. Compensation is different for every single disorder. So metabolic acidosis, in acidotic conditions, remember, bicarb is our metabolic determinant here. So to calculate compensation, we're going to look at PaCO2, which is our respiratory compensation, right? So what would our predicted PaCO2 be in metabolic acidosis and in metabolic alkalosis? And here we have something called Winter's formula, which you have to memorize. It's 1.5 times bicarb plus 8 plus minus 2. If PaCO2 falls in this range, we have appropriate compensation and no secondary disorder going on. All right, and then for metabolic alkalosis, we have this formula. Now you can memorize this formula, or a quick and easy way to do it is to look at 2/3 of the change in bicarb. So in metabolic alkalosis, your bicarb is going to go up, right? And then 2/3 of that, your CO2 should also go up by 2/3, because the CO2 is your bicarb is causing alkalosis, right? Your CO2 is going to want to go up to compensate for that, and so it's going to go up 2/3 as much for appropriate compensation. Next, we have respiratory acidosis and respiratory alkalosis. The thing to know about the respiratory conditions is that you calculate bicarb now, right? We're compensating with metabolic changes, and there's different values depending on acute or chronic. Now you can memorize each one of these formulas to try to predict the compensatory bicarb level that you'd expect, or you can use this handy little diagram here for respiratory compensation. Now this diagram is known as the 1, 4, 2, 5 or 1, 2, 3, 4, 5 triangle. Now here some people like to use different values, but this is the most common one I've found. So even in our algorithm, these ratios change, but I'll explain that later. Okay, so here we have a respiratory acidosis, as you can see, with high PaCO2. So this is acidosis, this is alkalosis, right, with our low PaCO2. Now for every 10 that the PaCO2 changes, you expect the bicarb to change with one of these values, 1, 4, 2, or 5, okay, depending on acute or chronic. Let's take an example. So our normal bicarb is 24, and our normal PaCO2 is 40. So if our PaCO2 goes up by 10 in an acidosis condition, let's say we have 50 here, right? Our acidosis 50, it went up by a factor on an amount of 10. Now for every 10, our bicarb now has to go up by either 1 or 4, right? So our new bicarb here is going to be 25, and our new bicarb here is going to be 28. It went up to try to compensate for this respiratory acidosis. 1 for every 10, right? So if this went up by 20, if we had 60 here, we would have 26, right? All right, so alkalosis, we have low PaCO2. So let's do another example. Let's say we're down by 20, right? So 2 times 10. So here we would have to decrease our bicarb by 4, right? Because it's 10, for every 10, you have to decrease by 2. So we have 2 10s, we're going down by 4, so now we're at 20 bicarb in a compensated scenario, right? And if the ratio is 10 to 5, now we're going down by 10, so we're at 14 bicarb for appropriate compensation. Okay, so I hope that made sense. Remember that the acute values, the compensations are going to be smaller than the chronic values. You're going to have higher compensation values for chronic and lower compensation values for acute. So you can remember 1, 2, 3, 4, 5, but you skip 3, so it's 1, 2, 4, 5. And acidosis is going to have a little bit smaller values, then alkalosis. Alkalosis is going to be larger. You can remember acidosis with AC, and it's less letters than alkalosis with ALK. Okay, so that represents our quick way to determine respiratory compensation by looking at if the bicarb changed appropriately or not. Next, we're going to talk about our metabolic acidosis. Now, after we've done our Winter's formula to determine compensation, we're also going to have to calculate anion gap, which is calculated with this formula right here. Sodium minus chloride plus bicarb, right? Our positive ions minus our negative ions to determine the gap. And one important thing to know is if our potassium is high, the formula and the range also changes. So 12 is here, and 16 is if we have high potassium, we have to include it in our formula, and the range goes from 12 to greater than 16 as being positive. Okay. So if we have a normal gap, which means less than 12, we have these causes, which are memorized by fuse cards. And if we have a high gap, which is greater than 12, we have MUDPILES, which is all of these causes here: methanouremia, DKA, and etc. So I'll give you a chance to look up all these causes. You can pause the video here right now and read up on the causes, and then we'll move on in just a second. Okay, so moving on. Once you have identified a MUDPILES HAGMA, high anion gap metabolic acidosis, so we have a positive anion gap, which is greater than 12, and it's our MUDPILES mnemonic. We also have to do something called a delta-delta. So positive anion gap, more work to do. A delta-delta is really a delta in the anion gap, or a change in the anion gap, over a change in the bicarb. Now that's going to tell you if you have a secondary disorder going on. So if you have a delta-delta of 1 to 2, that's normal. So you just have HAGMA in that case. If you have a delta-delta of less than 1, you have a hyperchloremic or normal anion gap and metabolic acidosis on top of your HAGMA. Okay. And if you have a delta-delta of greater than 2, then the situation gets kind of iffy. Either you have an additional respiratory acidosis or a metabolic alkalosis in addition to your HAGMA. So okay? So either we're adding a metabolic acidosis or a respiratory acidosis or metabolic alkalosis to our HAGMA if our delta-delta is not between 1 to 2. All right, moving on. This is a quick sidebar. It's just for fun, and we can dive into the physiology in a future video if you guys want to. But you can actually have an elevated or low anion gap in cases where you don't have any changes in the acidosis alkalosis status of the body. So there's certain areas where you can have a low anion gap. Usually when you order a BMP or a CMP, it'll give you the anion gap automatically. And sometimes you can see, oh, it's low, or oh, it's high, but this person's not acidotic, this person's not alkalotic. Now there are several explanations which you can just quickly reference to here. There's either hypoalbuminemia, which decreases the amount of unmeasured anions. There's paraproteinemia, so a lot of proteins with things like multiple myeloma, which increases the amount of unmeasured cations. And if you decrease the unmeasured anions and if you increase the unmeasured cations, you actually decrease the anion gap. Now, if you want to increase the anion gap, you can do things like have high phosphate, so hyperphosphatemia. So phosphate is actually negatively charged, so you increase unmeasured anions. And the low calcium or low magnesium, which are 2+, right? These ones are decreasing the unmeasured cations, which increases anion gap as well. So if you decrease cations, then you have, or increase anions, then you have increased anion gap, right? And the opposite goes for decreased anion gap. All right, so that was just a quick sidebar. If you guys want to jump into the physiology of the anion gap, we can do a whole video on that next time. All right, so high anion gap also requires, or HAGMA also requires the calculation of an osmolar gap. Now here's the calculation here, calculated osmolarity. And what you have to do is you compare the machine's calculated osmolarity in the serum versus your theoretical osmolarity here. So measured osmolarity minus calculated. This is theoretical, this is true, right? that gives you your plasma osmolar gap, and it's usually less than 10. If it's greater than 10, that means you have an osmotically active particle in the blood that's causing the ratio to be higher. And that's things like methanol, ethanol, right? Sorbitol. These are things that will increase the osmolarity of the blood, increasing also with it sometimes acidosis. So it will cause your high anion gap acidosis. And these are also part of the MUDPILES mnemonic, okay? So osmolar gap will also give you the etiology behind your high anion gap in some cases when you see that it's abnormal. Next, we have urine anion gap, right? So this anion gap you'll calculate only if you have a normal anion gap metabolic acidosis. So normal gap acidosis, your next step is calculating the urine gap. And basically what this has to do is it tells you if the excretion of ammonia or acid is good enough in the kidneys. So how you calculate this, it's not the same formula as the serum anion gap. It's sodium plus potassium minus chloride, right? So here are your cations, here's your anion, and these are not all the cations, anions in the urine, and we can go over the physiology of the urine anion gap in a further video, but you remember that the normal should be 0 to 10, and really negative values or values that are a lot greater than 10 will tell you the physiology behind this. Negative urine anion gap tells you that it's GI or severe diarrhea, and positive urine anion gap tells you that it's RTA or renal tubular acidosis. That's how you determine the etiology of metabolic acidosis with a normal gap. Is it kidney? Is it GI? Okay. Next, here we have a quick summary table of things you should look out for on the ABG. If you guys want to print this out before interpreting an ABG and help organize your thoughts, I found this to be pretty helpful on the wards. Okay. And here's our algorithm again. So let's do a quick summary just to make sure we've understood everything. So first we're going to look at pH. Are we acidosis, alkalosis? Then we're going to do metabolic or respiratory. Which change explains our pH, right? Is it our CO2 that explains our pH? Is it our bicarb that explains the pH? Then we're here, right, in our first line of our algorithm. And each one has its own different steps. So respiratory alkalosis. Now we're talking about compensation, right? So are we going to, in respiratory conditions, right, respiratory acidosis, respiratory alkalosis, we are calculating compensation with bicarb. By looking at the bicarb, is it compensating for our CO2? In respiratory alkalosis, is our bicarb going down, right? 2 for every 10 or 4 for every 10. Remember that cross I showed you with the 1, 2, 4, 5, right? Well, that's kind of how our rule goes here. But really what this algorithm shows is instead of using 4, 5, it uses 3, 4. So they use 3 instead of 4 here and 4 instead of 5. So 5 would be what we did. So as I told you when we talked about it, different people use different ratios. So here they used 1, 2, 3, 4, which I guess is easier to memorize, but other algorithms use 1, 2, 4, 5. Okay, so the endpoint is still the same. In acute, you have a less ratio than in chronic, and you're looking at the change in bicarb. In alkalosis, as you would expect, you want your bicarb to go down to compensate. So is it going to go down 2 for every 10, or is it going to now go down 4 or 5 for every 10 in chronic, right? Are you compensated for acute or chronic? And then respiratory acidosis, we still have these ratios. Are you going to increase your bicarb now by 1 for every 10 or 3 or 4 for every 10 in chronic cases to compensate? All right. And for metabolic alkalosis, now we're looking at PCO2 for our metabolic conditions. Is our PCO2 in our alkalosis case going up by 2/3 the amount of change in our bicarb from normal, right? Is the increase in PCO2 2/3 of the increase in bicarb? Now, metabolic acidosis has this special Winter's formula, which I would encourage you guys to memorize. And this is our special guy because we continue down a whole bunch of other calculations if we have this. So everything else you'll see kind of stops here at step 2. Metabolic acidosis, we take this even further, so that's why test writers love it. So now we look at our anion gap. We have a negative anion gap less than 12, or we have a positive anion gap greater than 12. Okay. For positive gap, we're looking at an osmolar gap, right? That's going to tell us if we have things like methanol, ethanol in our blood, things that will increase osmolarity, right? So our cutoff here is 10. If it's less than 10, your osmolar gap is negative. If it's not, it's positive, and it'll give you some clues as to what the etiology of your HAGMA is. Remember, this is high anion gap metabolic acidosis, right? HAGMA. This is just MA, metabolic acidosis, right? And then we also calculate our delta-delta for HAGMA, right? Our delta-delta is going to tell us other things about the condition. Remember, 1 to 2 is normal. So 1 to 2 is normal. If we have greater than 2, we have either metabolic alkalosis in that case, or respiratory acidosis. And then if we have less than 1, we can have a metabolic acidosis on top of that. So there's a bunch of conditions where our delta-delta will tell us that we have an extra thing going on if it's not between 1 to 2. All right, so remember that. And then if we have a just metabolic acidosis, pure and simple, less than 12, we look at our urinary anion gap to look for the etiology, right? And then the cutoff is 0 to 10 for normal. If we're negative, or if we're a lot greater than 10, that'll tell us something. So if we're a lot greater than 10, we're gonna look for RTA, and if we're negative, we're going to look for GI causes. So negative gaps are going to look for GI or IV fluids, and positive gaps are going to look for RTA. Okay, so after we've determined our metabolic acidosis, we're looking for etiology, and this is where we explore things like anion gaps to determine if we have a MUDPILES cause or not. This is where we determine urinary anion gaps to determine if we're dealing with the kidney or the GI tract, determine our osmolar gaps, see if we have an osmolar agent in the blood, and our delta-delta to tell us if we have an additional acid-base disorder on top of our HAGMA. Okay, so I hope this review was helpful in going over some acid-base problems, having a quick approach to them, and this algorithm helped you guys like it helped me. All right, I'll see you guys in the next video, and peace out.